Welcome to the Deep Dive, where we really try to unpack complex medical topics, giving you that essential knowledge you need, well, fast. Today, we're diving into something really crucial for every nursing student and practicing nurse out there: breast problems, assessment, and management. We're basing this deep dive on Lewis's Medical Surgical Nursing, the 12th edition, aiming for that focused clinical viewpoint.
Exactly. And our mission here is basically take all that dense content and distill it down, make it clear, structured, and hopefully engaging, especially for you, the nursing student. We want to cut through the noise,
Yeah.
hit the highlights. Pathophysiology, the key risk factors, how things present clinically, the diagnostic tests you'll see, and most importantly, the nursing management. Think of it as your fast track to being really well informed on this.
And that's exactly what you need, isn't it? It's not just about rote memorization. It's about getting that essential knowledge quickly, understanding different angles, and really building the confidence for actual practice. And yeah, tackling those NCLEX style questions. So let's start right at the beginning. That moment a patient finds a lump or notices a change, what's the immediate emotional reaction you usually see, even before a diagnosis?
Oh, it's almost always intense anxiety, fear, just immediately. The potential impact on psychology, social life, sexuality, body image, it's huge. It really drives home why understanding breast health isn't just clinical knowledge for us as nurses. It's fundamental to compassionate care.
That's such a critical point. So when we're talking about the common issues, what conditions are nurses most likely to encounter?
Well, beyond that initial wave of anxiety, the things we see most often range from benign stuff like fibrocystic changes, fibroadenomas, to more complex things like intraductal papilloma, ductal ectasia, and then, of course, breast cancer. That statistic, the 1 in 8 lifetime chance for women, it's sobering. And while it's much rarer in men, it happens, which just highlights why personal risk awareness, knowing about genetics, knowing the screening guidelines is absolutely vital.
That 1 in 8 figure definitely makes you stop and think. So let's unpack those screening guidelines for early detection. What are the key takeaways for nurses, especially distinguishing between average and increased risk?
Okay, so for women considered average risk, and that means no personal history, no strong family history, no known gene mutations, no chest radiation before 30. The American Cancer Society generally recommends starting regular screening mammograms at age 45. Now, there's an option to start annually between 40 and 44. Then, ages 45 to 54, it's annual screening. After 55, they can switch to every other year or keep going annually, as long as they're generally healthy with a life expectancy of, 10 years or more. And here's a really key point for nurses. The ACS doesn't recommend the clinical breast exam, the CBE, as a screening tool on its own for average-risk women.
Okay, that's important, not as a standalone tool. What about women at increased risk?
Right, for them the conversation changes. We're talking about women with maybe a strong family history, a known BRCA mutation, previous breast cancer, certain biopsy results showing atypical cells, or that history of chest radiation before 30. These women really need to talk with their provider about the pros and cons of starting screening earlier. And that might involve using 3D mammography, sometimes called tomosynthesis, and potentially breast MRI. Plus more frequent clinical breast encounters. And clinical encounter here means more than just the exam. It includes assessing risk factors, education on reducing risk, and yes, a CBE is part of that broader picture.
Got it. So if the CVE isn't the main screening tool for average risk, how does breast self-examination BSE fit in? What should nurses be teaching about that?
That's a great question. Research hasn't shown that BSE actually reduces deaths from breast cancer, but it's still really valuable for increasing a woman's self-awareness. As nurses, we should definitely still teach its importance, how to know what's normal for your body, what your breasts usually look and feel like. The real goal is empowering women to notice changes: nipple discharge, a new lump, dimpling, anything different, and report it promptly to their provider. Early recognition is still key.
That makes total sense, focusing on awareness. Now, let's say something is found, either through self-awareness or screening. We need diagnostic studies. What are the go-to tools, and what should nurses understand about them?
Usually we start with radiologic studies. Mammography is the primary one, uses x-rays, can spot lumps you can't even feel. Digital mammography tends to be more accurate, especially in younger women who often have denser breast tissue. And then there's that 3D mammography, tomosynthesis, which gives a clearer layer-by-layer view. Helps reduce false positives, which is a big plus. On the images, we often see calcifications, tiny calcium deposits. Most are totally benign, but sometimes they can be linked to cancer, so they need evaluation.
What other imaging techniques are commonly used?
Ultrasound is often used right alongside mammography. It's excellent for telling if a mass is solid or if it's a fluid-filled cyst. It's also the go-to for evaluating lumps in pregnant or lactating women, and it's invaluable for guiding biopsy needles accurately. And then there's MRI. It's not typically routine screening for everyone, but it's recommended as a screening tool for women at very high risk, like those with a close relative carrying a BRCA mutation.
Okay, so imaging identifies a concern. But for a definitive diagnosis, you need tissue, right? What biopsy methods will nurses likely see?
Absolutely. Biopsy is the gold standard for diagnosis. The common ones you'll encounter are fine needle aspiration, or FNA. That's where a thin needle draws out fluid from a cyst or cells from a solid mass. Then there's core biopsy. It uses a slightly larger hollow needle to get small samples of tissue, gives more information than FNA. Often, for lumps you can't feel, these core biopsies are guided by imaging like mammography, ultrasound, or MRI to pinpoint the exact spot. That's called stereotactic or image-guided biopsy. Nowadays, these minimally invasive biopsies are standard, but sometimes an excisional biopsy, where the whole lump is surgically removed in the OR, might still be needed.
Right, so we screen, we diagnose, but it's so important to remember, like you said, not every change means cancer. Can we walk through some of the common benign breast problems nurses will definitely see?
Yes, let's do that. Probably the most common complaint is mastalgia, just breast pain. It generally falls into two types. There's cyclic mastalgia, which, as the name suggests, lines up with the menstrual cycle. Usually it's a diffuse tenderness or heaviness in both breasts, and it tends to get better after menopause. Then you have non-cyclic mastalgia. No link to periods, can be constant or come and go, usually just in one breast. It might be caused by trauma, fat necrosis, or even nerve pain radiating from the chest wall, like costochondritis. From a nursing perspective, the big thing is reassurance. Pain alone isn't usually a sign of cancer. Management often involves simple things: a good supportive bra, warm or cool compresses, maybe reducing caffeine and fat intake, and over-the-counter pain relievers.
Reassurance sounds key there. What about infections, like mastitis?
Mastitis is an inflammation, most common in women who are breastfeeding, usually within the first few months after giving birth. It shows up as a localized area that's red, painful, tender, often warm, and the woman might have a fever. It's typically caused by bacteria, often staph, getting in through a cracked nipple. Treatment is antibiotics. And importantly, breastfeeding should usually continue, unless an abscess forms or there's purulent drainage. A crucial point: if it doesn't clear up with antibiotics, further investigation is needed to rule out inflammatory breast cancer, which can mimic mastitis. And if mastitis progresses, you can get a lactational breast abscess that needs drainage, often guided by ultrasound, plus antibiotics.
Okay, let's talk about fibrocystic changes. You mentioned this is incredibly common. How can nurses best explain this to patients who might be worried?
Yeah, it affects a huge number of women, maybe 30–60% in their reproductive years. You can explain it as the breast tissue sort of overreacting to normal monthly hormone fluctuations, estrogen and progesterone. This leads to excess fibrous tissue, maybe some overgrowth in the ducts, and the formation of tiny fluid-filled sacs or cysts. Sometimes people describe the texture as lumpy or ropey. This can cause discomfort or pain because of the inflammation, swelling, maybe some nerve irritation. Patients often feel one or more lumps, usually round, easy to move, not fixed, and they often get bigger and more tender right before their period. Sometimes there's nipple discharge, but it's usually greenish or brownish, not bloody. The absolute key nursing intervention here is reassurance. These changes do not become cancer. And teach breast self-awareness, emphasizing they should report any new lump that doesn't seem to change with their cycle.
That focus on cyclical changes versus persistent lumps sounds really important for patient education. What about fibroadenoma?
Fibroadenoma is the most common benign lump we see in young women, teens, 20s mainly. More common in black women, actually. These feel very distinct. Usually small, maybe 1 to 3 centimeters, painless, round, smooth, well-defined edges, and really mobile, like a little marble that slips away when you try to press on it. Firm, rubbery texture. No skin retraction, no nipple discharge usually. They grow slowly and often stop growing, though pregnancy can sometimes make them enlarge. Diagnosis needs a biopsy to be sure it's benign. If it is, and it's small and not causing symptoms, often it's just watched. If it's growing or bothersome, it might be removed surgically or with cryotherapy. For nursing, knowing this is typically benign in this age group helps manage patient anxiety significantly.
Good to know. Are there any other benign conditions nurses should be aware of, even briefly?
Yeah, a couple more. Nipple discharge itself needs attention. While often benign, if it's spontaneous, coming from just one duct, and especially if it's bloody or clear like water, it needs evaluation cytology of the fluid, maybe imaging to rule out underlying issues like An intraductal papilloma. An intraductal papilloma is a small, benign, wart-like growth inside a milk duct, often causing that bloody discharge. It needs removal, as there's a slightly increased cancer risk associated with some types. Also, male gynecomastia, breast tissue enlargement in men, often temporary during puberty or due to hormonal imbalances, medications, or other health issues. While usually benign, if an older man develops a firm, discrete lump, it needs a biopsy to rule out male breast cancer, which, although rare, does occur. Routine male breast assessment is important.
Okay, we've covered a lot of the benign landscape. Now let's shift focus to breast cancer. You mentioned the stats: most common cancer in women besides skin cancer, second leading cause of cancer death. Let's start with etiology and risk factors. What are the heavy hitters?
Well, the two biggest non-modifiable risk factors are simply being female and getting older. The risk really climbs after age 55. Hormones play a big role too. Estrogen and progesterone can act as promoters for certain cancer types. That's why things like combined hormone replacement therapy, long-term estrogen-only therapy, and even some aspects of reproductive history can influence risk. Then you have the modifiable risks. Things like significant weight gain after menopause, being sedentary, smoking, high fat intake, obesity, and alcohol consumption. Even things like night shift work are being studied.
What about the genetic link? We hear a lot about BRCA genes.
Right. Genetics are definitely important, but maybe not in the way everyone thinks. Only about 5–10% of all breast cancers are strongly linked to inherited gene mutations. The most well-known are BRCA1 and BRCA2. These are tumor suppressor genes, and mutations in them significantly increase the risk of breast, ovarian, and some other cancers. For women identified with these mutations, really intensive screening is recommended, and options like prophylactic surgery removing ovaries or breasts might be considered to drastically lower risk. It's a very complex decision. But, and this is crucial, about 90% of breast cancers are sporadic, meaning they result from somatic mutations that happen during a person's lifetime, not inherited ones. So while family history is important, most breast cancers aren't directly inherited.
That's a really important distinction: inherited versus sporadic. So when cancer does develop, how does it usually behave? How does it progress? And what factors determine the prognosis?
Most breast cancers start in the lining of the milk ducts, ductal carcinoma, or the milk-producing lobules, lobular carcinoma. It can initially be in situ, meaning it's contained within that duct or lobule, or it can become invasive, breaking through the wall and growing into the surrounding breast tissue. Once invasive, it has the potential to metastasize or spread. The most common route is through the lymphatic system, typically to the axillary lymph nodes under the arm first. From there, or via the bloodstream, it can spread to distant sites like bones, liver, lungs, and brain. Key factors that help predict the prognosis and guide treatment include the tumor size, the number of axillary lymph nodes involved — more nodes usually means a worse prognosis — how differentiated the cells look under the microscope — less differentiated means more aggressive — and those crucial biologic markers: estrogen receptor, ER, progesterone receptor, PR, and HER2 status.
You mentioned ER, PR, and HER2, and different types like ductal and lobular. Can you elaborate on the main types of breast cancer nurses should know? It sounds like it's definitely not just one disease.
Absolutely not one disease. So about 20% are non-invasive, or carcinoma in situ. Ductal carcinoma in situ, DCIS, is the most common type of non-invasive. It stays within the milk duct but can potentially become invasive if left untreated. Treatment usually involves surgery, lumpectomy, often with radiation, or mastectomy. Sometimes hormone therapy is used too. Lobular carcinoma in situ, LCIS, is different. It starts in the lobules, but is now generally considered a benign condition that indicates increased risk for developing cancer later, rather than being a pre-cancer itself. Usually it's managed with close observation, maybe risk-reducing medication.
Okay, so DCIS is treated, LCIS is more of a risk marker. What about the invasive types?
Right. Invasive or infiltrating breast cancers, one's broken out. The most common type by far, about 80%, is invasive ductal carcinoma, IDC. Starts in a duct, invades the tissue, can metastasize. Invasive lobular carcinoma, ILC, starts in the lobules. It can sometimes be harder to detect on mammograms because it often grows in a line rather than a distinct lump, maybe presenting as subtle thickening. It can also metastasize. A really distinct and aggressive type is inflammatory breast cancer, IBC. It's rare, maybe 1–3%, but grows fast. Instead of a lump, it makes the breast look red, swollen, warm, and causes that characteristic skin thickening called peau d'orange, like an orange peel. This is because cancer cells block the lymph channels in the skin. It's often mistaken for mastitis at first and has a poorer prognosis. Then there's Paget disease of the breast. Starts in the ducts but spreads to the nipple and areola, causing itching, burning, maybe bloody discharge, and skin changes like scaling or erosion. Often there's an underlying cancer, usually DCIS or invasive ductal, deeper in the breast. And one more to be aware of is triple-negative breast cancer.
This means the tumor tests negative for estrogen receptors, progesterone receptors, and HER2. It tends to be more common in younger women, Black and Hispanic women, and those with BRCA1 mutations. It's generally more aggressive, more likely to recur, and doesn't respond to hormone therapy or HER2 targeted drugs. Chemotherapy is the main systemic treatment.
Wow, quite a range. So putting it all together, what are the typical clinical manifestations nurses should look for during an assessment that might suggest cancer?
The classic sign is often a lump or thickening. Typically, a cancerous lump feels hard, has irregular or poorly defined edges, doesn't move easily within the breast tissue, it feels fixed, and is usually painless, especially early on. The upper outer quadrant of the breast is the most common location, but it's not always a lump. Other signs can include that unilateral nipple discharge we mentioned, especially if it's clear or bloody, nipple retraction or inversion turning inward, skin dimpling or puckering, or that peau d'orange appearance. Any persistent change needs evaluation. And the main complication we worry about is recurrence either locally in the breast area, regionally in the lymph nodes, or distantly as metastases.
Okay, so a diagnosis is made. What happens next in terms of diagnostic studies to really stage the cancer and plan the best treatment?
Right. After diagnosis, we need more info to predict risk and guide therapy. Axillary lymph node analysis is absolutely crucial for staging and prognosis. The standard now is usually sentinel lymph node biopsy, SLNB first. The surgeon identifies and removes just the first 1 to 4 lymph nodes that drain the tumor area, the sentinel nodes. If these are negative for cancer, it usually means the cancer hasn't spread to the nodes and more extensive node removal isn't needed. This avoids a lot of potential side effects. If the sentinel nodes are positive or if they can't be identified, then a full axillary lymph node dissection, ALND, might be done, removing maybe 12-20 nodes. We also look closely at the tumor size, how differentiated the cells are, and we test the tumor tissue for those key markers. Estrogen and progesterone receptor, ERPR status, and HER2 status. ERPR-positive tumors are likely fueled by hormones, so hormone therapy is an option. HER2-positive tumors have too much of a growth-promoting protein, so HER2-targeted drugs could be used. Nowadays, we also often use genomic assays like Oncotype DX. These tests analyze a panel of genes within the tumor to help predict the risk of recurrence and, really importantly, whether a patient is likely to benefit from chemotherapy in addition to hormone therapy, especially for certain ER-positive, HER2-negative cancers.
That genomic testing sounds like a big step towards personalized medicine. So, based on all this information, what are the main surgical options?
Surgery is usually the primary treatment for localized breast cancer. The two main approaches are breast-conserving surgery, BCS, or mastectomy. Breast-conserving surgery, often called a lumpectomy, removes just the tumor along with a margin of surrounding normal tissue. It aims to keep as much of the breast as possible. It's almost always followed by radiation therapy to the remaining breast tissue to kill any microscopic cancer cells left behind. For many women with early-stage cancer, survival rates with lumpectomy plus radiation are the same as with mastectomy. But not everyone is a candidate for BCS. Maybe the tumor is too large relative to the breast size, or there are multiple tumors, or they've had prior radiation. A mastectomy is the removal of the entire breast. A total or simple mastectomy removes the breast tissue, nipple, and areola. A modified radical mastectomy also removes the axillary lymph nodes, but preserves the pectoralis major muscle underneath. There are also techniques like skin-sparing or nipple-sparing mastectomies, which aim to preserve the skin envelope or the nipple-areola complex for better cosmetic results during reconstruction. But there are specific criteria for who's eligible. And for many women undergoing mastectomy, breast reconstruction is a really important part of the process. It can be done at the same time as the mastectomy, immediate or later, delayed. It can involve using implants or using the patient's own tissue flaps from other parts of the body, like the abdomen, back, or buttocks.
Okay, so surgery is key. You mentioned radiation often follows lumpectomy. What other roles does radiation therapy play?
Right, radiation is a major player. Its main adjuvant role is after lumpectomy to reduce the risk of the cancer coming back in that breast. It could also be used after mastectomy, especially if the tumor was large or lymph nodes were involved, to reduce recurrence risk on the chest wall or remaining nodes. It's also used palliatively. If the cancer has spread, say, to the bones or brain, radiation can be very effective at shrinking those metastatic tumors to relieve pain or other symptoms. The most common type is external beam radiation therapy. Usually involves daily treatments Monday through Friday for several weeks, maybe 3 to 7 weeks, depending on the technique. Common side effects nurses need to help manage are fatigue, skin reactions like redness or peeling, like a sunburn, and sometimes breast swelling or soreness. There's also brachytherapy or internal radiation. For some early-stage cancers after lumpectomy, radioactive seeds or sources can be placed directly into the lumpectomy cavity for a shorter period. This delivers a high dose right where it's needed most.
Makes sense. Now let's tackle drug therapy. This seems like a really complex area with chemo, hormone therapy, targeted therapy. Can you break down the main categories and the key nursing considerations?
It is complex, but crucial. Drug therapy can be used neoadjuvantly, meaning before surgery, usually to shrink a large tumor to make surgery easier or allow for breast conservation. Or it's used adjuvantly after surgery to kill any cancer cells that might have escaped and reduce the risk of recurrence. And of course, it's the main treatment for metastatic disease. So first, chemotherapy. These are cytotoxic drugs that kill rapidly dividing cells, usually given as a combination of drugs. Common regimens have acronyms like AC, CMF, CEF. Given intravenously, typically in cycles over 3 to 6 months for adjuvant, neoadjuvant therapy. The side effects are what nurses spend a lot of time managing. Nausea, vomiting, diarrhea, hair loss, alopecia, fatigue, and importantly, bone marrow suppression. This leads to low white blood cells, neutropenia, increasing infection risk, low red blood cells, anemia, causing fatigue, and low platelets, thrombocytopenia, increasing bleeding risk. Also, chemo-brain issues with memory and focus is a real thing. Specific drugs have specific toxicities too, like doxorubicin, the A and AC, can potentially damage the heart, so monitoring is key.
Okay, chemo targets rapidly dividing cells. What about therapies that target the cancer's specific drivers?
Exactly. That's where hormone therapy comes in, but only for cancers that are estrogen receptor, ER positive, and or progesterone receptor, PR positive. These therapies work by blocking the effects of estrogen or lowering estrogen levels in the body. The main type of estrogen receptor blocker is tamoxifen. It basically sits in the estrogen receptor on the cancer cell, so estrogen can't bind and stimulate growth. It's used in both pre- and postmenopausal women, often for 5–10 years. Big side effects are menopause-like hot flashes, mood swings, vaginal dryness. But nurses must educate patients about the serious risks: increased chance of blood clots, DVT, PE, stroke, cataracts, and, in postmenopausal women, uterine cancer. Any unusual vaginal bleeding needs immediate reporting. The other main class is aromatase inhibitors, AIs, drugs like anastrozole, letrozole, exemestane. These work by blocking an enzyme called aromatase, which is needed to make estrogen in postmenopausal women, mostly in fat tissue, not the ovaries. So AIs are generally used only in postmenopausal women. They tend to cause different side effects than tamoxifen, mainly muscle and joint pain, and importantly, increased risk of osteoporosis and fractures because they lower estrogen levels so much. Bone density monitoring is crucial.
Tamoxifen for pre- and postmenopausal, AIs mainly for postmenopausal. What about HER2 positive cancers?
Right, if a cancer is HER2 positive, meaning it overexpresses the HER2 protein, which signals cells to grow, we can use targeted therapy. The first and most famous is trastuzumab, Herceptin. It's a monoclonal antibody that attaches to the HER2 receptors on the cancer cells and blocks them from receiving growth signals. It's dramatically improved outcomes for HER2-positive breast cancer. Other HER2-targeted drugs exist too. Main side effects can include flu-like symptoms, infusion reactions, and potentially heart problems, decreased heart function. So cardiac monitoring is essential, especially if the patient has pre-existing heart issues or is also getting certain chemotherapies like doxorubicin. And finally, immunotherapy is a newer player, primarily for certain types of advanced or metastatic breast cancer, like triple-negative cancers that express a marker called PD-L1. These drugs help the patient's own immune system recognize and attack the cancer cells. They have their own unique set of potential immune-related side effects that nurses need to be aware of. So for nurses, it's less about memorizing every single drug and more about understanding the category of drug, its purpose, chemo versus hormone versus targeted, the major potential side effects for that category, and how to educate and support the patient through their specific regimen.
That's a really helpful framework. Okay, we've covered diagnostic, surgery, radiation, complex drug therapies. Let's bring it all back to the nurse. What does comprehensive nursing management look like across this whole journey?
It's truly holistic, starting with a thorough assessment. Subjectively, you're gathering that detailed health history, family history, any prior benign breast disease, their menstrual and pregnancy history, hormone use, genetic testing results, radiation exposure. Functionally, asking about things like weight changes, bone pain, possible mets, nipple discharge, changes they've noticed in their breast, cognitive changes, chemo brain, and importantly, their stress levels and coping mechanisms. Objectively, you're assessing for palpable lymph nodes, especially in the axilla and neck, looking for signs of metastasis like an enlarged liver or signs of fluid around the lungs, pleural effusion, and carefully documenting the characteristics of any breast lump or skin changes like dimpling or that peau d'orange look. Your planning needs to be collaborative with the patient. Goals typically include ensuring they can participate actively in decision-making, helping them adhere to their treatment plan, managing side effects effectively, ensuring they have adequate support systems, and emphasizing the importance of follow-up care.
And what about the preventative and health promotion side?
Huge role for nurses there. Health promotion involves reinforcing those modifiable risk factors, encouraging a healthy weight, regular exercise, limiting alcohol, eating nutritious foods, not smoking. It also means promoting adherence to the appropriate screening guidelines based on their individual risk. For high-risk women, this includes discussing the pros and cons of genetic counseling and testing for BRCA and other relevant mutations, and supporting them through the complex decisions about preventative medications or prophylactic surgeries.
What about during the acute phase, like around surgery?
In acute care, especially pre-op and post-op, the nurse's role is critical. Preoperatively, you're often providing immense emotional support during that stressful waiting period for results or surgery. You're clarifying information about treatment options, helping them weigh pros and cons for informed consent, and really supporting whatever decision they make. Post-operatively, focus shifts to managing pain effectively, teaching drain care if they have drains after mastectomy or ALND, and crucially, promoting arm function on the affected side. This means teaching specific exercises like wall climbing, pulley exercises, rope turning, as shown in Lewis's figure 56.7, starting slowly and progressing to prevent stiffness, contractures, and maintain muscle tone and circulation. You're also educating about signs of infection or complications to report, explaining follow-up plans, and discussing options like breast prostheses if reconstruction isn't done immediately.
You mentioned arm exercises. What are some key potential complications nurses need to manage after treatment?
Lymphedema is a big one, especially after axillary lymph node dissection or radiation to the lymph node areas. It's a chronic swelling in the arm, hand, or even chest wall on the affected side due to impaired lymphatic drainage. Manifestations include heaviness, aching, fatigue, numbness, tingling, and visible swelling. Prevention is paramount. Teaching patients to avoid BPs, IVs, injections in that arm, protect it from injury, burns, or infection, maintain a healthy weight, and do gentle exercises. If it develops, management involves specialized therapy like manual lymph drainage, compression bandaging or garments, elevation, and continued exercises. Nurses play a huge role in education and monitoring for this. Another issue is post-breast therapy pain syndrome, PBTPS. This is persistent pain, tingling, burning, numbness, shooting pain, itching in the chest, armpit, or arm that lasts beyond the typical healing period, like more than 3 months. It's often due to nerve injury from surgery, chemo, or radiation. Management involves NSAIDs, sometimes antidepressants or anti-seizure meds like gabapentin, physical therapy, and supportive care. And related is phantom breast pain, or sensations in the breast that's been removed. It's real pain, originating from the brain's interpretation of nerve signals, similar to phantom limb pain.
It sounds like beyond the physical, the psychological impact must be immense.
Oh, absolutely enormous. Psychosocial support is a cornerstone of nursing care here. The diagnosis and treatment can profoundly affect body image, self-esteem, sexuality, and feelings of femininity or masculinity. We need to acknowledge the specific challenges men with breast cancer face, too often feelings of isolation or embarrassment in a disease perceived as female. As nurses, our role is to routinely screen for psychosocial distress, create a safe, non-judgmental space for patients to talk about their fears and concerns, help identify their existing support systems, family, friends, encourage open communication with partners, and make timely referrals to mental health professionals, counselors, social workers, or patient support groups like those offered by the American Cancer Society or Susan G. Komen. Addressing concerns about sexuality and intimacy requires sensitivity and openness.
And for the increasing number of people living long-term after breast cancer.
Yes, survivorship care is critical. This involves ongoing monitoring, regular clinical exams, continued emphasis on breast self-awareness, monthly exams, and typically annual mammograms for the rest of their lives. Other imaging is usually only done if symptoms arise. It's also about managing long-term side effects and promoting healthy lifestyle choices. And importantly, gerontologic considerations. Remember, age is the biggest risk factor. But treatment decisions for older adults shouldn't be based on age alone. We need to consider their overall health, other medical conditions, comorbidities, functional status, and personal preferences to ensure the chosen treatments are both effective and tolerable for them.
Okay, one last area before we wrap up. Mammoplasty. This covers surgeries to change breast size or shape, either cosmetic or reconstructive, What's the nursing focus here?
Whether it's for reconstruction after mastectomy or cosmetic procedures like augmentation or reduction, our approach needs to be professional and non-judgmental. Providing clear information is key, helping women have realistic expectations about outcomes and understand potential risks like bleeding, infection, or issues with implants like capsular contracture, scar tissue tightening around the implant. For breast reconstruction, it's often a vital part of psychological recovery after mastectomy, can significantly improve self-image and help women cope. It restores the breast mound, but it's important they understand it doesn't restore lactation or normal nipple sensation. Reconstruction can use implants, saline or silicone, sometimes preceded by a tissue expander that gradually stretches the skin. Or it can use autologous tissue flaps using the patient's own skin, fat, and sometimes muscle from the abdomen, like TRAM or DE flaps, back latissimus dorsi flap, or elsewhere. These flap procedures are more complex surgeries with longer recovery times, but can provide very natural results. Nipple reconstruction is often a final stage, done later. Nursing care post-mammoplasty involves careful monitoring of surgical sites and drains for bleeding or infection, meticulous dressing changes, pain management, and again, significant psychosocial support, addressing body image adjustments. For augmentation or reduction, ensuring they wear the recommended supportive bra and understand activity restrictions is also important. So just to quickly recap the absolute essentials for you, our future nursing colleagues. Grasp those screening guidelines and risk levels. Know how to differentiate common benign issues from potentially malignant findings. Understand the multimodal approach to breast cancer diagnostics, surgery, radiation, the different drug therapies, and always center your care on the nursing process. Thorough assessment, setting priorities, collaborating with the team, educating your patient, and providing that crucial psychosocial support. That's your power in this field.
That's a fantastic summary. And as you head into your careers, here's something to think about. With genetics and personalized medicine evolving so rapidly, how will you integrate these new insights into caring for patients with breast conditions? What new questions will this constantly evolving landscape raise for you in your own practice? Thank you so much for joining us on this deep dive into breast problems. We really appreciate you tuning in.